afternoon, good evening. Thank you so much for joining us for the weekly press briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. I will now hand over the floor to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon to all the participants from wherever you may be at this moment. And a very warm welcome again to join us for this week's press conference. It's always a great pleasure for us to have this opportunity to account back to you on the progress that we are making on the content of the management of Mpox and other emergencies. Let me also first start with apologies from the Director General, who could not make it because of circumstances beyond his control, and also the Minister of Health. Both are going to join us during the press conference of next week. Now, with those few words, Director, if you can get the presentation on the screen. Yes, I would like to start first by saying that we are currently visiting countries. I think our teams, Sierra Leone, currently, we have a team of about 6 people that are visiting the country. It was an opportunity for us to meet with the leadership, as you can see on the picture there, with His Excellency, the Minister, and also the Executive Director of the National Public Health Agency, and all key players in the response to take stock of the progress that has been made since the last visit of the IMST 2 months ago, and also chart the way forward, as we are all committed to accelerate the progress and get really to a stage where all countries on the continent can control this outbreak. And we've discussed support in different areas of the response, including surveillance, in particular community-based surveillance, in the area of laboratory reinforcement, in the area of data, in the area of infection prevention and control, and also vaccination, given the fact that they have received already the donation that came from the DRC. Next. It's coming back again. I don't, every time that they flash it from Great. Yeah, sincere apologies. I think now everything's back to normal. Let me start with the overview of the public health event on the continent. As of June 18th, we have so far accounted about 132 moderate to high-risk events on the continent, of which 37 high-risk and 95 moderate risk. But if we compare that with the numbers we had last year in 2024, which were 219, it shows that we are already gearing toward exceeding that number in 2025, then, which is really a confirmation that Africa remains on the upward trend when it comes to public health events. Now, the top 5 diseases that have been recorded include cholera, Mpox, measles, dengue, and Lassa fever. And during this presentation, we'll cover the first 2, that's cholera and Mpox. Next. Now, let's start with Mpox. Now, on the continent, since the beginning of 2024, we've reached 148,000 cases, 40,000 confirmed, 1,816 suspected deaths, and 200 confirmed deaths, giving us the case fatality rate of 1.2% on the suspected cases and 0.5% on the confirmed cases. But when we look at the year 2024 and the year 2025, we also see that the same upward trend has been maintained. Already on the suspected cases, we have already recorded 70,499 cases as of EP week 23. That is about 90% of all the cases that were reported in 2024, and we are not yet half of 2025. And on the confirmed cases, we have already 20,936, exceeding the 19,000 that were reported in 2024. That means that most likely this year we'll see double or more than double those numbers. But on AP week 23, we have noticed a slight decline on the number of notified cases compared to the week before, 2,700 compared to 3,100, but an increase on the number of confirmed cases, 822 versus 745. Just to say that the number of confirmed cases, because of the time it takes from notification to sample collection and then analysis and the reporting of result, might not necessarily correspond to the cases of that week alone. And this on the dates among suspected cases, we have 20 cases that have been reported compared to 3 the week before. And on the confirmed cases, we had 4 confirmed cases reported dead compared to 6 cases the week before. That to say that overall, we see a slight decrease on the number of notified cases, but a slight increase on the number of confirmed cases. But also, what is important also is the fact that the contribution of Sierra Leone now is going down. Sierra Leone, the week 23 contributed 40% of all confirmed cases. That is coming down from 53% that we reported last week. Next. On the spread of the different clades, very interesting really picture on the continent that confirm that we are dealing with multiple outbreaks on the continent. At least 4 different clades, also with different lineages within those clades. We have clade 1A in Central Africa, which has been reported in at least 5 countries. That's Central African Republic, Gabon, DRC, Cameroon, and the Republic of Congo. We have clade 1B that has been reported in Central Africa, in East Africa, and also Southern Africa. You know, we have countries from Angola to Burundi, Ethiopia, Kenya, Malawi, Rwanda, South Sudan, Tanzania, Uganda, Zambia, and Zimbabwe that has reported clade 1B. We have clade 2A that has been reported in 3 countries, that's Cote d'Ivoire, Guinea, and Liberia. And then we have clade 2B reported in the rest of the countries in West Africa, as well as Morocco. And in addition to that, we also see countries that are reporting combinations of different clades, like Guinea has got clade 2A and 2B, the same with Liberia. We have DRC also reporting a combination of clade 1A and 1B. We have Cameroon reporting clade 1A and clade 2. And we have Congo Brazzaville that has reported 3 clades, clade 1A, clade 1B, and clade 2B in the same country. I think that's why we are saying that Africa, we are dealing with multiple concurrent outbreaks. Next. Now, if you zoom into the 3 countries that have the highest burden of Mpox in terms of the number of confirmed cases on the continent, these 3 countries, DRC, Uganda, and Sierra Leone reported here, account for 91% of all the confirmed cases on the continent over the last 6 weeks. But we can see that the trend in all countries is the same. We have now started a downward slope across many of these high burden countries, which is really good news, including even in Sierra Leone, where we are right now. You remember about 4 or 5 weeks ago, we reported that really the numbers in Sierra Leone were really worrying. But now you can see that over the last 4 to 5 weeks, Sierra Leone has now maintained that downward slope that is very encouraging. To also confirm that the strategies that have been recommended in our 2nd phase plan, the one that we've called 2.0, are now showing that the intensification strategies that were combined with the integration and legacy strategy are starting now to show some light at the end of the tunnel. Next. In the DRC in particular, I think many, they have reached about 111,000 cases. Just to confirm again that DRC has been the country that has reported the highest number of cases, both suspected and confirmed, at almost 25,000 confirmed cases, 1,800 deaths among the suspected, 116 deaths among the confirmed, with the case fatality rate of 1.6% among suspected and 0.5% among the confirmed cases. But we see that in week 23, we observed a decline on the number of notified cases, 1.8 thousand compared to 2.1 thousand the week before. But the number of confirmed cases was higher, really doubled or more than doubled. From 123 to 274, but that is because of the backlog, on the laboratory result. I think that was reported in the DRC that explained the situation. But the picture of confirmed cases remains the same. We have clade 1A and 1B that are also circulating in the country. We have males now making 69% of all cases, and the children now accounting for 15% of all cases. But in terms of the testing, we see some very encouraging improvement. Remember that DRC testing coverage has gone down up to 13%. Now they've gone up again to reach 46%, which is very encouraging. And the strategy to decentralize and also address the issue of sample transportation are still being scaled up. And also activities have also resumed on the eastern part of the DRC. Now, the testing rate stands now at 77%. The testing positivity rate is at 33%. And the turnaround time, very encouraging, also almost 85% of the results that are retained within 48 hours of reception in the laboratory. And currently, the country has got 1.5 thousand active cases, and now a total of about 46,000 contacts that have been reported. But it is important to also mention that there are 6 provinces in the DRC that account for the vast majority of cases. That's almost 98% of those cases reported in Epi Week 23 came from those 6 provinces, which are Nord and South Kivu, Kinshasa, Tanganyika, Chuapa, and Equateur. Next. In Sierra Leone, where we are taking this press conference from, 4,800 suspected cases since the beginning of the outbreak in January, 3,800 confirmed, 20 deaths, giving a case fatality rate of 0.5%. But when you look at the epi curve, you can see that downward slope that I was talking about, very encouraging. And the same trend has been maintained during week 23, that the notified cases, the confirmed cases are all going down, as you can see the numbers. But on the profile of confirmed cases, we have clade 2B that is still circulating as confirmed through sequencing. Males make 51% of all cases, and children just about 4%, meaning that it remains an adult outbreak that is going on. On the testing, I think the coverage is good. 100% of the cases are tested. The testing rate also stands at 100%. I think the problem that remains is the test positivity rate, although slightly going down. Remember, it was above 90%. The last time we reported 93%, now starting to go slightly down at 89%. And we really want to see this test positivity rate to go down even further below 50%, because of the fact that it is just a reflection of the passive surveillance that is going on. As you can see also that they have had active cases now at 958, but contacts that are listed only about 5,932, in total. But if you look at those that have already been discharged and we take them out, it's about 1,700 contacts that are still active. The turnaround time for result is very good, about 2.5 days. Now, just to say that for Sierra Leone, among the remaining or the persisting challenges, I think we have the surveillance that is really passive, and all efforts are being put now to strengthen the community-based response with the involvement of both epidemiologists at the district level, but also community health workers to be able to accelerate the active search of cases. And the country even presented to us yesterday a strategy just to intensify surveillance toward more active surveillance. Let's move on. Now, in Uganda, the same good news, I think, is maintained across. When you look at the epi curve, we see that since the peak of the outbreak around week 11, we've seen that downward slope that has been maintained for more than 10 weeks now, which is also very, very encouraging. But the result of week 23 have shown a slight increase, on the number of confirmed cases compared with previous week. That is from 113 to 149. That's a 32% increase. But the deaths on confirmed cases were reported 0 during the week. Now, on the profile of confirmed cases, is still clade 1B that is circulating. Males making 56% of all cases, and children only below 15 years, only 11%, meaning again that it's an adult also outbreak. In Uganda, the testing coverage is very good at 100%. The same with the testing rate, also at 100%. And the test positivity rate now is at 49%. With the turnaround of results also good at 72 hours. There to say that we have now 61 districts out of the 145 that remain really active. But it's important to say that what has been observed in Uganda is that the mortality is mainly associated with comorbidity linked to HIV, I think, which really confirms also the vulnerability of people living with HIV, in particular to the case fatality related to Mpox. And also that I think we had observed also a sharp decline of cases in the city of Kampala, which really shows that the outbreak is getting slowly toward the control phase. And we really need to encourage all the strategies that Uganda is doing the intensification to get to the finish line. Next. In Burundi, it is the same trend, still on the decline. Again, I've seen we over 8,900 suspected cases, 4,000 confirmed, but only 1 death. I think Burundi is one of the countries that has maintained a very low case fatality rate, close to near 0. And when you look at the situation during AP week 23, I think the downward slope has been maintained, both on the notified cases and also on the confirmed cases. And the profile of the cases is still clade 1B that is circulating, males making 52% of cases. But unlike Uganda, we see that in Burundi, children make about 47% of all cases. Good performance also on the testing coverage and rate, which both stand at 100%, and the test positivity rate that has continued to go down now at 18%, which is really good news. The number of active cases is now at 58 only. But it is important here to say that from the peak of the outbreak in week 43 of 2024, we have seen a sharp decrease by about 95% in the number of cases reported in Burundi, which is really a confirmation of the sustained downward trend that we have observed. But now I think the country is just working to get to the full control of the outbreak. Next. In Liberia also, we're seeing the same trend, again, downward slope, 909 suspected cases, 175 confirmed cases, but very good performance, 0 deaths, so far a case fatality at 0%. Now, when you look at the performance during AP week 23, the same trend has been maintained. On the notified cases, we see decline from 87 the week before to 55 week 23. The same on confirmed cases, a decline from 41 the week before to 22 during week 23. And on the confirmed cases, it is actually 2 clades that have been identified, clade 2A and clade 2B. Males make the vast majority of cases, about 86%, and children make 54% of cases. On the testing side, testing coverage stands at 87, the same with testing rate, also 87%. The test positivity rate is at 22%, and the number of active cases right now stands at 66. That to say that Liberia is also among the countries that have seen that decline, both on the number of suspected cases and confirmed cases. But it is important to mention that in the case of Liberia, 83% of active cases are now receiving home-based care. Just to emphasize that in countries where, whether it is a national policy or because of constraints that are related to the bed capacity, there are patients that are taken care of at home, but it is important to have a clear strategy of home-based care to provide the necessary IPC and the necessary support to those homes that are taking care of people at home to avoid the continued spread of the outbreak at that level. And also important to say that Liberia has also done very well on the contact tracing, with a ratio of 1 to 17 contacts. You know, our target is 20. I think this is one of the best performances that we have, and that 70% of contacts are being actively followed up, which is really a reflection of a surveillance system that is working. Next. Now, if you can switch from the EP data to vaccines, to say that it's about 3 million doses of vaccines that have been donated cumulatively, 2.9 million that have already been shipped, and 11 countries that have received those vaccines. And they make about half of the vaccines are MVA-BN, another half LC16. I think that was donated by the Japanese to the DRC. Just to say that there are 7 countries that are already vaccinating and 4 that are not yet because of challenges related either to the cases or to the availability of funding. And that there are 15 countries that have already granted the regulatory approval for the use of MVA-BN. Now, the most recent shipment is the one that happened yesterday here in Sierra Leone. I think they received 75,000 doses from the DRC as part of the bilateral donation between those 2 countries. Next. Now, some of the highlights is that the vaccination of LC16 has already started in the DRC, in the Kinshasa, the capital city, since June 14th. I think that is going ahead. I think the last information we got, there were more than 120 people vaccinated, but that continues. We are still to receive the most recent data. And also important is that the LC16 is also used for the vaccination of children. And DRC is one of the countries that have granted the emergency authorization, use authorization for the vaccination of children below the age of 18. Already with the vaccination using MVA-BN, 23% of the people that were vaccinated were children below the age of 18. Next. Now, on the surveillance side of it, I think there are great efforts that are going on to improve the data and especially integrate the data from surveillance with the data from the laboratory, with the data from the case management centers, and data from vaccination. I think there was a team from Africa CDC that visited the University of Oslo. Also there to discuss how DHIS2 can become that platform, given the fact that it is used in more than 40 countries on the African continent, to also integrate, in addition to data for programs, also integrate data for emergency management. And that is an effort that is quite advanced as part of the legacy of Mpox, to ensure that the next outbreaks find the surveillance, at least the data platform, at a much better place than we were when we started Mpox. Next. Now, that is it for Mpox. Now, I'd like just to present briefly a few slides on the cholera situation, to say that where we are right now, we reported the meeting that took place at the beginning of the month, the high-level meeting of head of state from the 20 most affected countries that issued a call to action to have a bold response to cholera on the continent. Now, 22 countries have now been affected, reporting a total of 163,000, almost 164,000 cases as of June 16 this year. If we look at that number again, we're getting close to half of the year. If you look at that number, it means that if we continue at the same trend, this year we'll have much more cases than we had in 2024. But we are hoping that the current intensification effort are going to bend that curve. And also by June 16, already 3,273 deaths recorded compared to 4,700 the entire year 2024. Now, also to say that Africa accounts for the vast majority of cases. We reported this, that the data we have by May compared to with the global is 60% of all the cases globally that are in Africa, and almost 94% of cases of deaths that have been reported on the continent. Next. Now, if we try to zoom in on DRC, it is just from week 1 to week 23, it's about 32,089 cases that have been reported, 693 deaths, a case fatality of 2.2%. That is of great concern. You know, the WHO's threshold is less than 1% case fatality rate, but we see that in the most affected countries, all of them are above that threshold. For the week, AP week 23, there were 1,237 cases reported compared to 1.5 thousand reported the week before. That shows a significant decline, in the number of cases. But when we look at the case fatality rate, I think there were 43 deaths reported compared to 36 reported the week before. Now, on the people affected, I think the great concern is about 40% of all cases that are among children below 15 years. But on the response side, the OCV coverage in the DRC is 7%, and the main hotspots are about 5 provinces, Okatanga, North Kivu, Sud Kivu, Olomami, and Tanganyika, I think that are the most affected. In terms of some of the drivers, locally is flooding. As you remember, we just reported last week the issue of flooding in the DRC, in particular, even in Kinshasa at the time. That increased water contamination in South Kivu and Tanganyika. There's also the cross-border spread, and also the challenges related to the urban water system. I think that also contributes to what we see. But just to say that now we are working on the personalization of the call to action that came from our head of state, and the IMST is now discussing how we can integrate also cholera in the continental response, given also the financial crisis that is going on globally, and the push for more results, more efficiency, and more sustainability. In terms of efficiency, we like to say how we can leverage some of the existing capacity already and structures to manage also the continental cholera response. Next. In Angola, we are seeing this downward trend, which is very interesting, both on the number of cases, but also on the case fatality rate. As a total, I think 25,295 cases reported between week 1 and week 23, 731 deaths with a case fatality at 2.9%, even much higher than the 2.2 we just presented for the DRC. During AP week 23, we are seeing a decline in the number of cases. It's 956 compared to 1,782 the week before. It's also the same on the case fatality rate also. We are seeing now a decline. There's 13 deaths compared to 33. That brings the case fatality rate to 1.4% for the week 23, which is even less than half, the average case fatality of 2.9. That to say that Angola is going in the right direction. We just need to support the country to accelerate and intensify the current efforts to get them also to control. Now, the main hotspots now that account for 76% are Bengo, Benguela, Luanda, Namibe, and Kwanza. But it is very important to also say that there are 3 provinces that benefited from the OCV campaign, not the vaccination campaign. Those were Luanda, Bengo, and Ikolo Ebengo. Now, what we are seeing is really the decline of cases in Luanda and Bengo, and Ikolo Ebengo that is reporting no case for now. That really to confirm that we are seeing some positive results there as the effect of the vaccination that took place in those 3 provinces. Next. In South Sudan, we also see an encouraging downward trend if you look at the AP curve, both on the number of cases and also on the case fatality rate. Now over 54%, almost 55,000 cases reported from week 1 to week 23, 983 deaths. That's a case fatality of 1.8%. But when we look at what happens in AP week 23, we see again a sharp decline on the number of cases, about 65%. That is from 1,500 cases reported in week 23, they only reported 543 cases in that week. But the mortality went up. That's 8 cases reported that week compared to 3 the week before. In terms of the profile of the people that are most affected, males make 49%, it's almost half-half, and the children account for 47% of all cases. I think that's why we see the increased vulnerability of children to cholera in South Sudan. Now, on the other highlights, OCV coverage reached 81%. And there are 2 provinces that are the hotspot, that's Unity and Jonglei. And in terms of the key drivers, we know that there's the insecurity that is going on right now, that has been going on in South Sudan. And we see the influx of refugees also from Sudan. More than 500,000 arrivals. And you can also imagine what strain that put on the wash systems, in the context, in the areas that they are received. There are also records of flooding in the Unity states, where 60% of the boreholes were submerged, and in the context of a high open defecation rate that we had reported earlier. I think those are some of the real drivers, of the cholera outbreak, and that Africa CDC, as part of the call to action, will be also working with the AU Peace and Security. There was a mission that was already conducted on the 11th of June to assess the situation, and we also need also to continue that collaboration during the mounting of the intensification of the response to help the country control the outbreak in very challenging situations. Next. In Sudan, also, as we can see, the last 3 weeks, we see a decline also that has been also maintained. But in total, over 27,000 cases reported, 470 deaths, a case fatality rate at 1.7. But during week 23, we see the declining trends that just see on the epi curve, 1,379 cases compared to 3,754 the week before. We have 26 deaths compared to 27 the week before. And in terms of the people that are affected, males make 52% of cases and 52% of deaths, and children below 20 represent 34% of all cases and 35% of all deaths. Now, the challenge in Sudan is that the OCV coverage is very low, 2.8%. And the two main hotspots are Khartoum, the capital city, and White Nile. They have to say that in terms of the drivers of the outbreak, 90% of Khartoum's water plants are non-functional. And there's also overcrowding in the IDP camps in Darfur, and in the context also that of reducing funding that makes sure they don't have enough funds really for water chlorination right now. I think those are some of the main drivers of the outbreak in Sudan. Next. Now, in summary, we like to say that we are seeing really some light at the end of the tunnel on the Mpox front. I think most of the countries are now going down. The cases and deaths are reducing. But the most encouraging result is what we see in Sierra Leone, because that was the country in the last week that was reporting the highest number of cases and accounting for more than half of all the cases. But now we see now they've gone down now in terms of the contribution to all the cases. I think both the cases and also the suspected and confirmed cases, which is very good news. I think that's the reason why we are here, to see how that effort can even be accelerated. But we also need to put some effort in the DRC, for example. There are always challenges in terms of testing, and also work on reducing the case fatality rate, the test positivity rate in a number of countries where we have seen that still high above 50%. And I really, on the cholera, I think we are still getting concerned with the 22 countries that are reported that are being affected. And we even see Cote d'Ivoire and Namibia also recently reporting new cases. That the call to action from our head of state is timely. I think the IMST will be able to report come from next week how we are reorganizing to be able to integrate also the cholera response into the Mpox response. And also that it is extremely important for us as we move forward that our plan 2.0 had already integrated some elements, to be able to push also on the efficiency. Again, we had three main strategic focus on intensification, integration, and the resilience. I think this is also the opportunity for us to operationalize that integration that we spoke about in the plan, to show that we are also really give you for the next phase of the discussion. Over to you, Dr.
Thank you very much, Dr. Ngashi. I would like to recognize the presence of the Minister of Health of Sierra Leone, Dr. Austin Dembi. Dr. Austin, can you hear us? Okay, I think he may be having a few issues with his connection. I will now move.
I think I see
Yes.
the minister is connected. Perhaps we can ask people that are close to the minister, the microphone is muted. We'll be delighted to hear from the minister as well on the great effort now, the commendable effort that are going on in Sierra Leone that are leading to the downward slope that we just reported. Over to you, Director.
Thank you very much. Let's cross over to the floor. We have, let's see, we have Kemo Cham from Mano Reporters. Kemo, you have the floor. Over to you.
Hello there. Yeah, thank you. So I had a question for the minister. Hopefully, if he comes on, you can read it because I sent it earlier. But for now, I wanted to ask a question in relation to doctor's presentation. You mentioned earlier some vaccines shipped from DRC to Sierra Leone. I wanted to know what's the rationale behind that, considering both countries need the vaccine. Is it because DRC doesn't need it as much as Sierra Leone does now? Or what is it? Thank you.
Thank you, Kemo. Let's take the next question before we have the responses. We have Janice from Bloomberg. Janice, you have the floor.
Hi, thank you again. I just wanted to ask regarding cholera. In terms of the rise that we're seeing, are the funding cuts leading to greater cholera outbreaks in any way? I realize there are a myriad of factors that are contributing, from climate change and war through to a number of other things. But if you could give any context or sense of how the funding cuts are affecting what we're seeing in the cholera outbreaks.
Thank you. Back to you, Dr. Ngashi.
Yes, thank you very much, for Director, and thanks to both Kemo and Janice for the questions. I think just to say that on the question regarding the donation of 75,000 vaccines, I think that that's part of the bilateral cooperation between member states, which does not go through Africa CDC. And it's not the first time that we have seen that. You remember that we had Nigeria also donating vaccines to Rwanda. I think that question, whether DRC doesn't have enough, I think we are not in a position to answer that question. I think it's up to the two countries really to perhaps give some element of answers to what you are saying. But where we sit, this is as much as we get the international solidarity, I think solidarity among African countries is also something that we have seen already. But the rationale behind that, I think it is the involved parties, I think, that are in better position to explain that. Now, Janice's question on the cholera, you remember that's an important point that we just mentioned, that you have what we see recently is that the global health financing cuts, we expected that they will have an impact. We even mentioned there that they're also having an impact on the capacity of Africa and some of the member states to respond to an outbreak like this. But also, as we say, that the decline in funding has already been playing a role, not only now, I think over the last 4 years. You remember that's the reason why Africa CDC has come up with what we call the green paper, because we observed that there were two things that were happening at the same time, weakening the capacity of really response in Africa to outbreaks in general. And then cholera is just the present one that we can talk about, is that the ODA to Africa has been going down. We've lost about 70% of the ODA between 2021 and 2025. We moved from 81 billion to about 25 billion now. And that number with the announcement of this year is even much lower than that. That means that the reduction of funding to Africa can also explain the underinvestment in the water, sanitation, and hygiene that contribute to the situation that we see now with cholera. That's the reason why you'll see that at least 18 countries, cholera has been a protracted kind of outbreak that has been really sustained over the recent years. But even now also, the fact that there are these cuts, I think countries have to make very, very difficult decisions, in the context of concurrent, really multiple outbreaks. As you know, we are dealing with Mpox, we are dealing with cholera, we have measles going on, as we reported, we have Lassa going on. We had Marburg also, then we had Ebola. I think then it becomes really, really challenging when the funding is going down. I think just to say that the short answer is yes. Now it's up to us to find now African solutions to the African challenges that we are facing. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the next question. We have a question here on the Mpox situation in Ethiopia. The question is, Mpox is becoming a serious health problem with a total of 18 confirmed cases. Despite its rapid spread, there is no preparedness or any strategies that are in place to mitigate the impact. What is the plan of Africa CDC in mobilization and support? And then we cross over to the floor. We have Esther Nakazi, a science journalist from Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Dr. Ngashi, for this webinar. So my two questions are about, one, what explains the 14.3% deaths of children under 18 years in Uganda from Mpox? And I do not think that we did have vaccinations for young children in our country below 18 years. I just need you to confirm that. And secondly, the digitalized surveillance system that you talked about, how will that work and integrate data across Africa when we have different capacities across the continent? Thank you so much.
Thank you. Back to you, Dr. Ngashi.
Yes, thank you very much for those questions. One on Ethiopia, what is Africa CDC strategy? The Africa CDC strategy is defined in our action plan and our response plan. We had the first response plan that provided the strategies for the first phase. Now we have the second response plan, 2.0, that also declined, details the strategies for the second phase. But before we as Africa CDC, we believe in co-creation based on understanding the realities on the ground and based also on understanding what the member states themselves are already gearing to do. Because most of our countries, as you know, they do have experiences in managing an outbreak. I think where we come in is to understand what is the local capacity that they have and where are the gaps. And also an additional thing that we bring is also experiences from other countries. Ethiopia, I think we have the advantage of being based in Ethiopia. That's where our headquarters is. Now, we've seen the cases that are happening in the south in those 3 locations on the map, and the numbers have now reached 18 cases that are confirmed. There's an IMST team, I think, that is preparing to engage with the member state to be able to assess what is already on the ground and then agree with Ethiopia what are the additional support that they can get from Africa CDC and all the partners that are part of the IMST. I think that's where we are right now. But we are preparing for that mission to Ethiopia. That's as we are doing in all other countries. It is after we have engaged with the country, then we can then say that these are the strategies that are jointly agreed with the member state for implementation. Now, on the on Uganda in particular, I think there was no vaccination of children below 12, as we all know, that the emergency use authorization of Uganda cover children from 12 and above, 12 to 18. But as you know, that the outbreak in Uganda is one that is predominantly affecting the adults, but children, because it is 1B, also are affected because of the proximity in the families of the adults that are affected. Because of that continued exposure of children, that's why we are seeing for these children that are also affected. But primarily, it's an outbreak that is spreading among the adults. But what we had encouraged all the children or the member states to do is to issue emergency use authorization that cover children below 18, that's starting from 1 to 17. But that is the work that is left now for Uganda, as it is with many other countries, is also how do we then also, once the country issues an emergency use authorization below 12, the 1 to 11, I think the vaccines are there, they are available. I think they'll be used to also protect that community. On the digitalization, I think the reason why we prefer to use DHIS2, it is because it is the commonest data platform that is used on the continent. At least 40 countries in Africa out of the 55 member states do use DHIS2. Since it's already the choice that is made by government themselves, then it was much easier for us then just to improve a system that is already used by government themselves to then capture all the key data that are important for the preparedness and also response to outbreaks. And now, where there are other systems, because we have also seen countries that do have other systems that are in place, we are working with the IT specialists now, the ones that are working with IMST, where as I reported, there was a team that also went to Oslo to meet with the expert from the University of Oslo and the HISP teams that are already located in Africa, in South Africa, in Uganda even, in Togo, to see how we can then build the interoperability of systems. Because if a member state has already adopted another system to be able to manage its emergencies, then it's okay. The important is just to make sure that there is interoperability and transfer of data between those two systems. I think those are the two things that we'll be working on the digitalization. One is that where there are no other system or just the DHIS2 is the most predominant, we build into that predominant system. Where there's another system that has already been adopted, it is working, and then the government feels that there's no need to duplicate. We just created the interoperability of those two systems. Over to you, Director.
Thank you very much. Let's get the next question. We have Josephine now. Josephine, you have the floor. Josephine, can you hear us? Okay, let's take the next one. We have Modu, is a journalist in Gambia. Modu, you have the floor. Modu, can you hear us?
Yes. Hope you can hear me.
Yes, we can hear you. Go ahead.
In fact, I just sent the question. My question is, since countries like the Gambia didn't have cholera, cholera has not been spotted here for now. What programs does Africa CDC has to make sure that the disease does not affect this part of Africa?
Thank you, Modu. Let's take the next one. We have Bernard. Bernard, you have the floor. Bernard, can you hear us? Okay, let's take the next one from the chat box. We have a question on what ways is Africa CDC integrating integrating lessons from COVID-19 and Mpox outbreaks to strengthen its continental health emergency preparedness and response strategy, and how is this addressing the persistent challenges of surveillance and rapid diagnostic? Over to you, Dr. Ngashi.
Yes, thank you very much, Director, and thanks to Modu and colleagues for those very interesting questions. I think, if I start with the first question on the Gambia, where, our support to the member states includes both the preparedness, because we believe that it's better to prevent than to cure, and then the response, where the country has already moved into an outbreak. Now, what is extremely important is on the preparedness side of it. We have things that are localized, that means things that can be done, that we do at country level. We support the country level to, first of all, on the risk communication and community engagement, to ensure that the community has the information, to drive the behavior, both the preventive measures, to also drive the care seeking. Instead, they see something which might be suspicious of the disease, and seek care, for them to be identified on time, be advised. I think that's one area that we work. The second, we also work on strengthening the surveillance system with a clear focus on the community-based surveillance system, to make sure that we can pick up events as they happen at community level before they spread further, and be able to bring the expert and investigate to ascertain where it is the disease. If it is, then take the necessary response. That is very important. But then for cholera in particular, the weakest link in the prevention and response is the water, sanitation, and hygiene. Partly because you see that the health ministries have played really a key role in trying to push cholera, but we understand that cholera is multi-sectoral. It's not something that can be managed by health alone. I think that's why, if you even read the spirit of the call to action, that was really the result of the work that Africa CDC has worked with key partners like WHO and UNICEF, is to ensure that there is a major role on really building the WASH infrastructure in the countries, especially in the most vulnerable communities where we see the recurrent hotspots of cholera. I think those are the things that Africa CDC is working with the member state. But then on the continental level, we are also working to make sure that there's capacity on the continent for the local manufacturing of the medical countermeasures that are related to cholera, including the oral cholera vaccine. If you are aware, we are really pushing very hard for the transfer of technology on the continent, and there are at least 2 manufacturers on the continent that do have now capacity to produce oral cholera vaccines, starting the first from 2026 and the second one from 2028. Those are the things that really Africa CDC is very much committed to ensure that we have the direct support, but we also anticipate as the broader preparedness to push the self-reliance on Africa on its own soil. Now, on the integrations, I think there are important lessons that we have learned from COVID. Let me just start with, first of all, the inequities and unfairness in the availability of COVID vaccines. That was an outcry from the African people that led then our leaders, our president, to call for the local manufacturing of at least 60% of the vaccines that are used on the continent here in Africa. It is one of the things that also has motivated the fact that every single outbreak that you have, take note of it, Africa CDC is always pushing for the local manufacturing of the vaccine here. We have Mpox, we are pushing for the tech transfer and the local manufacturing of Mpox on the continent. We are now talking about cholera, we are pushing for the tech transfer and the local manufacturing of oral cholera vaccine on the continent. That is a lesson from COVID. Now, the second lesson is that through COVID, what we noticed that communities played a very important role on almost all the steps of the response. That's what now we have done this time, is to learn from there And during the Mpox outbreak, now also moving into cholera, we are now bringing the community response as one of the key areas that we are supporting our member states to also integrate. But in addition to that, we have just completed a survey on the continental level, where we've identified that we do have 1,005,000 community health workers that are out there. Now, we are now embarking on another initiative to work with the member state to make sure that all that 1 million community health workers that are out there have the capacity and the skills to be mobilized when there is an outbreak for them to play a key role in the response. Now, on the diagnostics, one thing that we have learned also is that Africa didn't have enough capacity on sequencing on the continent. We relied on just sending our samples outside to be sequenced outside the continent. Africa CDC used that as one of the priority areas to build the resilience of the African continent. We had only 2 laboratories, 2 member states that had capacity to do sequencing. And now with the support of Africa CDC, we've now reached 42 member states that Africa CDC has distributed the equipment and trained the biologists to be able to run the sequencing at country level. And it's also the same with Mpox. Now we've gone a step further, not only the sequencing, but also the decentralization of laboratory capacity for diagnostic, first of all, before we even get to the sequencing. I think that's how we are really applying those lessons of the future to build a much stronger system on the continent. Over to you, Director.
Thank you, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I'll hand over the floor back to you for your closing remarks.
Yes, thank you very much, Director, for facilitating this. And I would like to sincerely thank all the participants really for the continued support. We strongly feel that we are accountable to you, to keep you updated on what we are doing on the continent and what the African people are struggling with. I think next time, as I promise, is that we are keeping really the accelerator on getting all the member states now to the finish line. I think the first phase of our response is to bend the curve. As we can see that in almost all the countries now, the curve is going downward. We are all happy to see that trend, but we are not yet satisfied because the aim is not to bend the curve, the aim is to stop the outbreak. We count on all of you really on the roles that you have played to take the weight out there, to mobilize the needed support, for Africa CDC, the needed support for the Continental Incident Management Support Team, the needed support for the member states primarily, because that's where things are happening. And also that next time we'll be now studying how we can also broaden our support for other outbreaks to move toward that integration, that we have spoken about in the past, also included in our plan, especially the integration of the cholera response into the continental response, first of all, and also in the report that we are providing to all of you. We look forward to seeing you again next week at the same time, to get the report on what could have happened between now and Thursday next week. And with that, thank you very much, and a great rest of the day to all of you.